De Iván. Buenas.
Good afternoon. We are welcoming the members of the Presidium to please take your seat. Well, good afternoon. I am Sandra Treviño. I am on the Clinical Excellence Program with the HIV and Hepatitis A and the Social Institute of IMSS. And I would like to welcome all of you and a very warm welcome from Dr. Gabi Borrello. She couldn't be here, but she sent you her best greetings. And this is the second event because last year we had the first Congress. Honestly, the success was such that it was necessary to prepare the second Congress. The second Congress you will find during the next presentations and during the next days and presentation of free work, a big breakthrough in regards to attention to people with HIV. I hope that this Congress is going to be useful. I'm sure you will find great material, space for discussion, not only among the members of the medical community, but also civil society. That's why it's important, society and institutions together to reach a goal. I will give the floor and I will introduce the members of the Presidium. Thank you very much for your attendance. Álvaro Velarca, General Secretary of the CISS. Inter-American Social Security Conference. Dr. Mónica Guardo, she's a clerk representative from the Pan American Organization in Mexico, Organization of Health. Dr. Nayeli Fernandez Bobadilla, Minister of the Committee of the National Trade Union of Social Workers. Dr. Mauricio Hernandez Avila, Head of Economic Benefits of the Social Security Institute. Dr. Asa Cristina Lauren, Director of Planning for Transformation of the institution from the IMSS. Also, we would like to welcome Dr. Elvirio Alfredo Carrasco. He is the head of Inter-American Study of Social Security. And Dr. Daniel Pérez Larios, representing Dr. Letze de la Torre de Sencida. Thank you for the presence of all the heads of the medical union, heads of the different units and second-level hospitals and people who represent them. It's very important because they deal with these people, HIV patients. It wouldn't be possible to have this event without all the will and the presence of Dr. Analia Garcia, General Director of IMSS. She has been core for organizing this event. So without them, it wouldn't be possible to be all together. Thank you very much also, Dr. Humberto Medina, he's the head of clinical excellence. And our dear friend, Fabiana Maribel Cepeda, she's in charge of the nursing group of the Social Security Institute. And we will continue with this program with the words of Álvaro Velarca. He's the General Director Secretariat of the CISS. Thank you very much, Sandra. Thank you, all of you. People who are here with us, this is an honor to have you. This afternoon, I would like to greet Dr. San Cristina. She was my previous former boss and head. Thank you. Daniel Perez from Sencida, Dr. Hernandez. Thank you very much for this invitation yesterday to the IMSS Fair and Stand. Thank you for your effort, Dr. Monica Guardio from the PAJO, and Dr. Nayeli Fernandez. She's in charge of the CEN, the Trade Union of Social Workers. Thank you, Dr. Olivares and Dr. Carrasco. He's the head of CIE. Thank you so much for being here, and Alia. Jefa Fabiana, Fabiana Head, Luis Fabian, all of you, people who are here with us today. It's an honor to have you all, and especially our international guests. They had allowed us to see these experiences in the managing of the HIV patient. I would like, as usual, to start by greeting you all. I know that people who represent Dr. Robredo by the IMSS are here, but I want to greet you all. And on behalf of him, he is the chair of this Inter-American Social Security Conference. He has been checking on this Congress. Last Friday, he was trying to adjust the agenda to be here with us today. Unfortunately, it wasn't possible for him to be here, but he's always paying attention to what is going on in this conference and symposium for treating people who live on HIV from Social Security Institute. I want to tell you that this is a good opportunity for all of us to share breakthroughs on research, on the health sciences and social sciences, on the challenges they have, still on the pandemic of HIV. Currently, this Congress is taking place within a very important and complex context we have gone through by the COVID and the war and the consequences of climate change and everything, economic crisis, everything that has made these inequalities even harder and the gaps there are in order to try to reach the goals of the UN system to complete the HIV pandemic on 2030. Since this pandemic started and until 5 years later, 2.5 million people had HIV worldwide, and around 40.4 million had passed because of conditions related to HIV. We were listening the case of Colombia, and I was making some figures after the presentation of doctor from Colombia. Thank you for being here. Around 600 people in Colombia, which is a country which is half the population that we have on Mexico. So, and I was thinking about 600 people dying a year at Colombia. So 600 people. This auditorium has also the capacity of 200 people, so it is the 3 times more. That's a dimension of the problem still we are facing. And as you will see in some surveys that will keep on being during these 2-3 days and presentations. Sometimes it is due because it's a late detection. People arrive too late to have this test. When is it necessary to happen? That even having all these symptoms related to HIV, people are rejecting to have these trials, these tests. That's what we are facing, because the big challenge that we see is to move forward to detect earlier and timely. For 2022, 39 million people, we estimate, are living with the HIV all around the world. And to complete this HIV pandemic for 2030 is one of the objectives of Sustainable Development Objectives of the UN. This was adopted unanimously in 2015 by the member states of the UN. The lessons learned on the response around the world will develop a good role in the meeting of these objectives. Especially from that is the objective 3, health and well-being. And also I want to remind which are the commitments for 2030 that the planet has acquired. With all this cascade of 95% of people living with HIV, to know what's the status they are going through. That's the first challenge. has to do with the early detection. 95% of people who know the status are under treatment. 95% of those who are under treatment, they have reached the viral abatement, and this is because of the treatment and attention they have received. Additionally, NUCIDA had set some goals to put an end to inequalities in 2025. So I want to remind you, less than 10% with HIV key population to experience stigma and discrimination, less than 10% of people with HIV, women and children, to have these inequalities based on gender and violence, less than 10% of countries to have laws and policies that are to punish people who are not following them, to eradicate stigma and discrimination. This is the big challenge that we face. I am convinced, he says, and many people around the planet are the same, feel the same. That's what is inhibiting this detection test, what is making a barrier to be able to reach the first goal, first 95%, and has to do with early detection. People who live with HIV to know about the status. To reach the goals, it's necessary to overcome challenges. One of them is to reach very efficaciously all these populations affected by HIV with a timely diagnosis, and to provide them what they need, as to have clean syringes and to have all the medications and all the condoms and whatever they need, and to be available to provide PrEP and to support where they live and where they work, and to support everything. That's why we have this slogan on this Congress, society and clinicians together to reach a goal and to avoid HIV. And so we have to go to the communities for them to be also aware of it. I am gladly to have this to celebrate this type of symposium and conference, and it's good for you to have allowed us to be providing you the venue of the CISS, Dr. Borrallo, to be able to celebrate this Congress that is so important. And I do congratulate you because, as far as I know, the Mexican Institute of Social Security is the first institution at Latin American level that is developing these epidemiological models to know much more and accurately the population they need to reach. You let me know if I'm right, but this is an effort that is talking about leadership of this institution, which is the largest institution of Social Security in Latin America and the Caribbean, if we bear into account the number of insurance and population and the agencies. So they have been the leaders in this field in the continent. You will know more what it's all about, the analysis of these epidemiological models. But this information is core, so we know what to do, and the institution to know how to channel all these efforts to detect if we want to reach the goals at 2030. I want to remind you that the goals can be achievable. There are 5 countries that where they have had all these pandemic, and they have reported that they had reached the 95%. So let's have this encouragement. We have to go the last mile, focus on the right population to reach goals, and highlight the elements that had made it possible to reach the 95% self-test, PrEP, PEP, and the medicalization of the treatment. Those are the main incomes that these countries might have, or outputs that these countries have, and to reach the goal of 95%. When this Congress is over, we will be able to sign for second time this specific agreement that we have with the IMSS as of 2 years ago, to do a follow-up of the actions taken by this institution and to keep on developing these epidemiological models. So again, thank you so much to Social Security, to you people representing the different organizations, agencies that are part of this Congress. I wish you success in what is coming, and thank you again for your attendance. Good afternoon.
maestro Velarca.
Thank you so much. And now we invite Dr. Velarco from the IMSS. So, good afternoon. I want to say hello to you all from the Pan American Organization of Health. Mr. Jose Moya, the representative of Mexico, sending his regards. Of course, myself, Monica Guaro, who is the assessor for communicable diseases. I say hello to this honorable group, to Mr. Velarca, who is the General Secretary of the General Security, Mauricio Hernandez, who is in charge of social loans, Mr. Daniel Perelarios, in representation of Integral Wholesome Attention, Censida, Ms. Nayeli Hernandez Bobadilla, Secretary of Female Action from the Union, Mr. Emilio Carrasco. Sorry if I don't remember every name. And of course, I'm also saying hello to Ms. Sandra Carlota Treviño, who is the chief in the medical area, leader of the HIV program, Celia Duque Molina, who is in charge of medical benefits. For me, it's a true honor to be here with you today. I've been here for 8 months as a counselor. Some years ago, by 29, I remember having worked with Ms. Hernandez in a team formed by the World Health Organization to work along with you as Mexican professionals in that first pandemic caused by a respiratory virus, H1N1. But today we are here for something different, the AIDS, the World Day of AIDS. This day, and quoting the General Director of United Nations, comes in a decisive moment. The number of deaths related to AIDS has decreased in around 70% since 2004, when it reached a record number in deaths. However, AIDS still causes the death of one person every minute, and in Latin America, around 2.5 million people live with AIDS. In 2022, around 130,000 people got infected, and 33,000 lost their lives because of things related to AIDS. The number of new infections in the key population, that is, men having sex with other men or prostitutes, the trans people, users of drugs, and people in prison, is highly higher. It's higher than the general population. We should and we must end the AIDS as a threat to the public health by 2030, as it happened or as it was agreed in the Sustainable Development Agreement, just as we were reminded by our colleague. In order to reach this goal, we need to pay attention to the logo of this year, to the motto of this year of the World Day of AIDS, released communities. To end the AIDS, and in order to end the AIDS, communities have a very important role in the response. Organizations, community organizations, and affected communities by the virus, they are in the first line of the answer to HIV. Give the power to these communities is essential in order for them to develop their own strategies and to reach those people who have the need to access to the distribution of a self-test, the implementation of prophylaxis before exposition or PrEP, in the first level of attention and community centers and the immediate vinculation to the treatment. And that way, we can achieve a viral load that is undetectable. One person with a indetectable load won't transmit the infection, and that way we can cut the chain of transmission or infection. This way comprehends connecting the people with the support and the service they need, up to displaying the communities that pushes the action in order for all the people to make the right to access accessible. To win the battle against AIDS implies supporting those who are in the first line. That means that the leadership of the communities should be a central point of the programs, plans, and budgets and follow-up activities in AIDS. We should also get rid of the obstacles to the leadership in the communities and be sure that the civil communities have access to continue with their work. It is also important to mention that we need financing. This financing or this additional financing needs to include more funds to cover local programs aimed to people with HIV and for those initiatives to prevent directed or led by the communities. In the celebration of the Day of the Fight Against AIDS, we are calling the people to react and act to support communities in this task. We need guidelines and a surrounding that helps communities for providing services against HIV and warranty an insight of equity and health as a right. Thanks to the participation of every people, we can get rid of AIDS in the region of America. The community should lead, and we should work together to get rid of AIDS. Thank you. Thank you so much, Ms. Guardo. Now we are inviting Daniel Perez Larios in representation of Alexa de la Torre and from Sencida to listen to his message. Thank you so much. Thank you, Sandra. First of all, I would like to say thank you to all the members of this group, and on behalf of Alexa de la Torre, General Director, and all the people working in Sencida, we're very thankful for having us here in this event and the participation of every person here. As you all know, we are still facing challenges in order to end the AIDS. The last estimations estimates that you will be listening in these days reflect that more than 39 million people used to live with HIV by 2022. In our country, it is considered that around 3,070,000 people live with HIV, and that around 20,000 of them are the ones who have a recent diagnosis every year. It is also important to say that we should acknowledge that 3 out of 10 people in our country don't know their diagnosis, and 6 out of 10 haven't been able to control this infection. For this reason, our vision today from Sencida is to confirm the commitment in order to rush an answer and that it be translated in a reduction of the load of the virus that will help us achieve our goals of 495 that have been mentioned previously, in which one of the main goals is to improve the quality of life of the people. During the last years, we have made great progress. We have been able, and thanks to the work of all the health institutions in Mexico, and this is reflected in events such as this one, some achievements that I want to comment with you. Since 2019, we started with a treatment optimization of the antiretroviral treatment. This helps people to get or to go under a unique tablet with inhibitors, and thanks to that, the quality of these people has improved. Also, the national guidelines, including the treatments, avant-garde treatments with medicine or medication and use of inhibitors that I talked to you about. And something very important about these guidelines is that they are made both by clinical experts and also with the participation of community leaders. Likewise, we have paid special attention to decrease a vertical transmission or infection with prophylaxis through different kind of injections and with prophylaxis in the person who in the newborn, sorry. And it's also important to say that since 2020, we have implemented and improved the PrEP and PEP programs to strategies that we consider are indispensable in order to decrease the new cases of HIV in our country. Fortunately, and thanks to the work of all the national system of health and community leaders, it is possible now that people access to PEP as it is a medical urgency in the units of attention, and we hope that this will help us to decrease infections of HIV. However, we are still facing very important challenges. We need to be sure that no one should be left behind. Groups such as immigrants, indigenous groups, Afro-Mexican people, or people with some kind of disability should not be left behind. This can be achieved with differentiated services focused on these people who can experience a greater impact produced by this HIV infection. I want to mention a very important case, which is that of the people with a delayed presentation. In Mexico, more than 40% of the people coming to the health services come to us with very bad conditions, and the chances of their death is very high. For that reason, we need to work together, institutions and community leaders, because they are very important stakeholders to help this group of people. In the end, all this should be in the frame of efforts to train and literacy efforts as well for everybody. The health staff and communities should participate in this response. I want to remember the motto of this World Day. In order to get an effective answer against the HIV, the ones who should be in the front should be communities. Thanks so much for your attention. Thank you so much. And now we are going to receive Nayeli Fernandez Bobadilla, who is the Secretary of Substantive Equality. Thank you so much. Good afternoon, everybody. On behalf of our General Secretary, Mr. Arturo Olivares Cerda, he couldn't be here today, but he sends his greetings and success in your activities. I feel very proud and honored to be here in this table. I know many people of this table, the doctors who are part of this table. Mr. Alvaro, thank you so much for your welcoming. And it's also an honor to talk to you, address you in this very meaningful moment that marks the beginning of the Congress to help people with HIV, society and institutions to get the common goals. This will produce a lot of knowledge and perspective that will strengthen the capacity to address each of the challenges of our times. As workers of the health world, our responsibility is great, and this training will be a paramount step to improve skills to help people with HIV. At the same time, I want to acknowledge the institution because of the effort and continuous training which is necessary to offer a better quality in the attention, but also the training which is the tool with which workers can get security in the work they do. with the certainty of providing a better treatment, because we know that the medical attention in IMSS is not static, it's dynamic, multidisciplinary, and interactive, and it implies mobility and constant changes, which demands or requires new knowledge, because we know very well that we never stop learning. However, training has a duality. It's a right and also an obligation that offers development and commitment. So we have the commitment to take what we learn to our very everyday practices. Every interaction with a patient is it's a chance to make a difference. A focus that can improve not only the quality of those who live with HIV, but also to contribute to the fight against the stigma. It's important to remember societies and communities together to get the goals by sharing experiences between organizations, communities, and other countries without borderlines. That's the only way to get to a more egalitarian country. World, sorry. In conclusion, I want to say thank you to all the people for their active participation and the work that you will be doing during this training. I'm sure that the knowledge that you get here will be very important for your everyday work. The spirit of this training is thanks to the workplaces. As a union, we acknowledge the training in the people in IMSS, as well as the benefit of our patients. Let's work together to get a world where talking about HIV is something from the past. Understanding replaces stigma, and I really wish you a lot of success in the development of these activities. Thank you so much, Ms. Nayeli. I will say thank you to Celia Duque Molina, who is the Director of Social Benefits, which has been the person urging the attention to people with HIV and actions of prevention. Unfortunately, she didn't have the chance to be here today because she had an urgency. However, she says hello, and in this moment we have the video sent with her message. Good afternoon. We are celebrating our second Congress to improving the attention to people with HIV. We are thankful to the people who are here with us today, people from our country and from other parts of the world, from Cuba, Argentina, Brazil, Chile, United States, and United Kingdom. Thanks to you all. We have 500 people coming to this Congress virtually and 3,000 online. We will be doing workshops that will help us strengthen the way we can help the people with HIV. In IMSS, we have a protocol that links the hospitals and specialty units, as well as multidisciplinary team. We also come with technological tools with more than 7,000 people linked through WhatsApp. We have strengthened the preventive therapy with PrEPs. In December 2020. And we have been working since January 2022. We are still working. And all the doctors of the country can enter a website to get more information. So I'm very thankful with the whole team to run this international congress, to the Foundation of Health, to all the team, Ms. Trevino, and of course, all the participants that have helped us achieve these activities in regards to the attention of people with HIV. Thanks to you all, and I really hope that this will be very successful. In this moment, and just to finish with the protocol, I kindly ask you to stand up to sing the hymn of the IMSS.
El águila, una madre y su regazo, son símbolos de un amor indeclinable.
80 años IMSS.
Invitamos
Now we would like to invite the members of the Presidium to please come to for the picture that we are going to have as a protocol. Please come this way.
y a nuestros invitados a permanecer.
Please remain here, the rest of you. We will be starting shortly the scientific lectures that we have prepared for you.
Les pedimos
Please go back to your seats and remain there for the people who are on streaming, because we will continue with this agenda.
Ese iba a poner.
Solo van a cambiar este presidente, que yo todavía no. Necesita algo que le...
que lo saquen. En tanto iniciamos las
While we start these activities, you can see on the side the QR code, so to be able to listen this video streaming in Spanish.
por fin. Bien, pues muchas gracias por su permanencia.
Thank you very much for being here, and we will be starting with an activity. This Congress has been possible because of generosity of professors who are opinion leaders internationally, and I'm sure that you will be enjoying, very importantly, you will be taking away all this knowledge to share them on your clinical practice place. We have Dr. Marca Bofito. She's working at the Chelsea and Westminster Hospital in the UK. She is a consultant at the Chelsea and Westminster Hospital of the Foundation Trust, and he is the head of the leader in the therapy and HIV, and she's directing different projects. She founded the first HIV the clinic, and she's teaching as well. She went to the Italy, to the United States and UK, and she has a special formation on different treatment and medication by therapy. She has been published in more than 30 articles and journals and reviewed by peers. She has been involved in training and capacity building, and one place she has been there is at Uganda. She has been collaborating very successfully. I'm asking you a round of applause to receive Dr. Bofito.
Introduction, Sandra. Good evening, and thank you very much for having me here in Mexico City. Perfect. So you can see I'm going to talk about an update from IAS and a little bit also from EACS on two drug regimens combinations for the treatment of HIV. And I'm going to talk about both oral combination and long-acting combinations. Try to figure out how this works. Oh, sorry. So those were my disclosures. So just to make sure we all start from the same place. We are very much used to hear about clinical trials and clinical trial results because clinical trials are the solid, robust evidence that kind of approve treatments and give us the evidence base to practice our medicine. But after clinical trials, there's a lot of real-world data that are presented, and I think that real-world data are important to complement what we learn from clinical trials, and it is really what happens in real world, in clinical practice, and to the people that you see in your clinics. And because the clinical trials on two drug regimens have already been presented many times, you will see that my update is mainly on real-world data. So the first data that I would like to cover is from the COMBINE-2 study. This is about combining dolutegravir with a reverse transcriptase inhibitors, which could be rilpivirine, but it was mainly lamivudine. So we are mainly talking about the combination lamivudine-dolutegravir. And the COMBINE-2 observational real-world study looked at the rate of virological failure and the rate of the discontinuations and the side effects. And you can see all the results summarized there. They looked at the Kaplan-Meier estimates for two-drug discontinuations, and they compared it with the three drug regimens. And they concluded that in real-world clinical settings, switching to an integrase inhibitors and a reverse transcriptase inhibitors led to a high percentage of people maintaining an undetectable viral load and very low percentage of people discontinuing because of virological failure or because of side effects. So basically, the viral load again was maintained, suppressed, and this is really what I see personally in my clinic at Chelsea Westminster Hospital, where we actually look after 13,000 people living with HIV across 7 different clinics in Greater London. And I have to say that switching to two drug regimens, mainly lamivudine-dolutegravir, has become very, very popular, and for us is one of the preferred combinations. This is especially true in people who are aging with HIV because they're highly likely to have polymorbidity and therefore polypharmacy. So there wasn't much else on oral drugs because on oral 2DRs because a lot has been presented. So I'm moving on to real-world data experience with the combination of long-acting cabotegravir and rilpivirine. So you can see here all the studies and the clinical trials that led to the development that today we're quite familiar with, you know, like the phase 2 LATE-2 study, phase 3 Atlas, FLAIR, phase 3B, Atlas 2M, and so on. But also you can see that towards the end, there are some implementation studies that reflect a little bit more what happens in the real world and in clinical practice, and then also some real world studies that I will discuss. So let's just start from Caricel. At IAS, there were, and actually, sorry, and also at EACS, there were some updates of this study. So we're going from longer follow-up times at IAS, and then at EACS, they presented the European data of Caricel. Caricel was mainly a European study that enrolled people who had an undetectable viral load and started long-acting cabotegravir and rilpivirine intramuscularly every other month. Also, as part of the Caricel study, they randomized the patients according to the health professional treatment that was provided, because some centers received a lot of training in how to implement the injections and some centers didn't. So they looked at whether the outcomes were better in the centers who received a lot of training. What I think it's really interesting from the Caricel study is that if you look at the results of the questionnaires that were administered to the healthcare professionals, the perception of the implementation of the long-acting compared to what they answered 12 months later was quite different. Healthcare professionals were quite concerned about the risk of resistance for non-adherence patients, about enough staff to perform the injections, because obviously you do need to make a few changes in how you deliver care if you go from oral treatment to injectable treatment. They were worried about patient soreness because of the injections, about scheduling around patients' holidays or travels, and also about the lack of virological suppression because of missed visits. But you can see that the light gray percentages that express the concerns were at the beginning, before the study, and then the darker gray were a year later, 12 months later. So you can see that the concerns decreased remarkably with the experience and the confidence of having used injectables for a year. So the majority of healthcare professionals did express concern on capacity, but again, after a year, they kind of learned on how to manage that. Also, the time to implement the injectables was quite variable, but more than 50% of the clinics took between 1 and 3 months, and also in only a lower number of clinics took longer time than this. And this is what happened also at Chelsea Westminster, where I work. At the beginning, everything was a little bit slower and really reflected on, and we had dedicated sessions for people receiving injectables. But then the nurses who gave the treatments, the doctors who prescribed the treatments became much more confident, and now we just do it with much more naturally in a higher number of people. And then what it is really important is the perception of patients, of people living with HIV, of course. And interestingly, the majority of participants were not very concerned about the time they spent in clinic to receive the injectables, and thought that the time spent in clinic was acceptable. and also the rate of adherence to the injections on time was very, very high. And this makes me think that we shouldn't always think that if people are not adherent to pills, it means they are not going to be adherent to injections. And we're going to talk about one of the studies, the JAB studies presented at IAS, that I think really proves this. The virological outcomes of Carousel at month 12 were very high, approximately 87% in all the group studies. Other studies presented at IAS from the real-world setting were looking at virological outcomes in people who received the oralidine versus non-receiving the oralidine. This is a study from Germany in approximately 90 patients that showed that receiving or not receiving the oralidine didn't make any difference in terms of virological success. So this is quite important because it shows what it was shown by the clinical trials where the oralidine didn't affect the pharmacokinetics of the drugs or the rate of discontinuations or the efficacy of the drug. So this is the JAB studies that I briefly mentioned earlier. So this study from Australia looked at the implementation of long-acting cabotegravir and rilpivirine in a vulnerable population with complex needs. So we are talking about people in Western Australia who had shown previous adherence concern and challenges, and also had some difficulties in their socio-economical aspect of life. They all had kind of participation to their lives by social workers. They needed community service support, and they needed particular support to adhere to oral antiretroviral therapy. This is the study design. People were administered questionnaires to see how they were feeling about receiving the injectables, and people were followed for 48 weeks after starting the injectables, and they had an undetectable viral loads. And as you can see here, they all again had quite a high score in terms of socio-economic needs and support. Interestingly, the rate of adherence to the injections was higher than 90%, well above 90%. Again, suggesting that people who do not adhere to oral treatment for a long list of different reasons may be very happy on injectables. This is, for example, the case of one of the people who took part to the JAB studies, and you can see the viral load history where they took their oral treatment, viral load went down, and then they stopped again, and the viral load went back up, and then again they probably had adherence support, stopped the treatment, took the treatment again, viral load goes down, then stopped again the treatment, viral load goes up, and so on. But then they took part into the JAB studies, received their injectables, and their viral load remained undetectable. And I think this is part of the discussion when we think about antiretroviral injectable treatments. And the adverse events were quite limited. The patient-reported outcomes showed high level of acceptability of the injectables. But what I would like to stop for a second is on some of the sentences in the patient-reported outcomes, so in the qualitative research results section, that really underline how people feel when they're on injectables. You can see the word freedom appearing there in different reports from patients. People who struggle with taking oral therapy, struggled with anxiety about oral therapy, were concerned about forced disclosure because they had to carry their pills with them all the time, felt free because they were on injectables, and this remarkably improved their quality of life. And that's the conclusion of the study. Now, another piece of research which I think is worth mentioning because of the concerns sometimes around injectables. So we know that the clinical trials show that long-acting cabotegravir rilpivirine is non-inferior to oral treatments, and every other month in Atlas 2M was non-inferior to every month. But if we look at the numerical results, there is a slightly higher numerical increase in people who fail, and when they fail with resistance to NNRTIs and integrase inhibitors. So when the clinical trials were presented, we really started to think we need real-world data to tell us what happens in the real world. This study is from the Athena cohort that comes from the Netherlands, and they look at the effectiveness of long-acting in people living with HIV. And what they did, they had about 558 people on injectables, and they also had a control group on oral treatments. And they showed that the people, that 0.9%, so it was 5 out of 558 of the people on injectables failed with resistance, but this was similar to 1.8% of people who failed with oral treatment, which was the control group. So if you look at the Kaplan-Meier curves in terms of risk for virological failure while comparing the oral treatment to the injectable treatments, there was absolutely no difference. So the study author concluded that the efficacy in real-world settings of long-acting is the same of those of oral antiretrovirals. And this is why, I mean, because of the clinical trials and then also boosted by real-world evidence, the long-acting antiretrovirals now appear in 3 sets of international guidelines, like the EACS one, the DHHS one, and the IAS one, that they all recommend injectables in people living with HIV with an undetectable viral load that could benefit for the treatment, and especially the DHHS guidelines underline the fact that the injectables can provide a benefit for people who are anxious about adhering to treatment and also fear forced disclosure. So what do we do at Chelsea Westminster Hospital? As I said, we have many clinics, so we have a multidisciplinary team meeting. We discuss everybody who would like injectables in our clinics, and we look at all of these characteristics. We follow the guidelines, the guidance of the multivariate analysis that derived from the clinical trials that advises that when you have 2 or more factors, such as a high BMI, a subtype virus A186, or resistance to NNRTIs, you are more likely to fail treatment. So we look at that, so we make sure people don't have resistance to NNRTI, we make sure people are not co-infected with hepatitis B or are vaccinated for hepatitis B, and they don't have drug-drug interactions with strong inducers like rifampicin, and if people are undergoing TB treatment, we advise them to wait until they stop the rifampicin because it would decrease the concentrations of cabotegravir and rilpivirine because it's a strong inducers of the metabolic pathways of the drugs. So we look at all the clinical characteristics. We look also at the patient considerations and why the patients would like to start the injectables, and whether they travel, whether they are women of childbearing potential, and all the benefits the injectables could bring. And then we register the people on our app, which is the Click app, we follow people stable on treatment via an app today. We train nurses to lead this initiative, to see people who are stable with an undetectable viral load in clinic. And this is again, a service that is nurse-led and doctor-supervised and really helps us with our capacity. And people on injectable register with the app so that they can have all of their appointments for their injections on the app and also reminders about their injectable appointments. We discuss oral bridging. Data on oral bridging are now emerging from clinical trials and real-world data showing that people who cannot show up at the injections can oral bridge, and then if you oral bridge for less than a month, you can go back to your injections every other month, and if you oral bridge for more than a month, you need to receive the loading dose again. And importantly, although the clinical trial data and the summary of product characteristics tell us to oral bridge with cabotegravir and rilpivirine for up to 2 months, there is evidence that you can oral bridge with almost any antiretroviral combinations, and especially during COVID-19, when the clinical trials sometimes had to be interrupted because of the lockdowns and the restrictions of society, people took any antiretroviral regimens, and the most used combinations were containing dolutegravir. So in terms of conclusion on 2DR, especially injectables, research priorities include monitoring of real-life efficacy. And I think we need better strategies to prevent virological failure. We have seen Carousel that shows very high levels of patient acceptability and also real-life long-acting data that seems quite promising. Now, just to conclude, a couple of words on pre-exposure prophylaxis with cabotegravir, just for completion, although it's beyond the 2 drug regimens, but this is the future of PrEP, and we are looking at implementing cabotegravir PrEP in London, so we are actually moving from TDF and FTC, a 2DR PrEP, to a single drug PrEP. There is a lot for us to learn because although the phase 3 study, SPGTN 083 and 084, showed that cabotegravir was superior to oral PrEP, they are still observed some seroconversions on cabotegravir, which is what we are seeing in London also on TDF-FTC. We do see PrEP failures. And that's when the concept of the Levi syndrome was introduced, and this is for people who seroconvert on cabotegravir. These are the results of the HPTN 084. So I think that, again, PrEP information is following those of treatments, and long-acting are a promising, probably single drug solution for PrEP. And I think we are quite needy of real-world data of cabotegravir PrEP to increase our confidence before implementation. Thank you very much for your attention.
A ver si funciona. Si no. Hola, hola.
Tenemos tiempo para preguntas de la audiencia. Le agradecemos a la doctora Bofito su excelente presentación. ¿Pueden ustedes hacerlo de viva voz o
You can make your questions, so the microphone is over here.
are the main barriers that you have observed in real world at the time of the implementation of this therapy of cabotegravir and rilpivirine? Which are the main barriers that you
The
have?
main barriers?
Yes.
Okay, so it's a very good question. So the main barriers were fear of not having time to implement the injectables. Especially after COVID, you know, we are all a bit overwhelmed, burnout, and we have a lot of backlogs, and there was a lot of concerns about this is going to take too much. We can't do it. I challenge people and say, no, you need to get over it. You need to stop being fearful, because the fulfillment of seeing someone coming back on the injectables and talking about that freedom that I really wanted to mention and underline is incredible. It's really worth it. Not everybody needs it. You know, some people are very happy on their oral treatment and you don't need to do it. But so the challenge was really to convince the nurses, other doctors, sometimes the managers, you know, the hospital managers want you to see as many patients as quickly as possible, to say, no, this is worth it. And then, if I can already tell you, the phase after the challenge is people just got very confident. So we used to have 1 day for injectables, 1 nurse for injectables, 1 hour visit for injectables. Everybody had to have their oral in, so the nurse would get ready to give the injectables. This was the beginning. Can you see everybody? And so everybody was concerned, this is going to take the rest of our lives to give one person the injectable. Now, anybody comes into the clinic, the nurse sees them, they get the injectables, they go, they stay 20 minutes. The challenge has been overpassed, but at the beginning, that was the real challenge.
Okay. Thank you so much.
Tenemos tiempo para más preguntas de la audiencia, también de la...
We have time for more questions from the audience and also the internet transmission.
In 20 minutes he gets his injectable?
Even 20 now.
Oh, wow.
It used to be longer, you know. But also, the first visit is still long because you go through everything, through the visits, through the appointment. You can come a week later or a week earlier about your date appointment. You want to discuss. But now, when they come for the third, fourth, fifth, they know what they do. The nurses prepare the drug because the rilpivirine is in the fridge. They are experienced. They are nurses, so they can give intramuscular injection with no problem. The patients are confident. The first injection, they're a bit scared. They have a bit of pain, and then it's really much smoother than I personally thought. Too, I was one of those that, like everybody else, thought this is going to be a challenge. So it's much easier than at the beginning. Yeah.
Well, it's really a challenge. And in many places, such I think Latin America could be very challenging to implementation, but I think, as you say, it's worth it to see a non-adherent patient that finally adheres.
What about the cost of this therapy?
He's asking about the cost of the therapy.
I'm Italian, I don't do money. So they don't let us do any money. No, I'm sorry. They're more expensive than others. Every country is very, very different. You know, the costs are very, very different. Now, I have to be honest with you. What I don't think has ever been done properly is a real pharmacoeconomic model where you put the virological failure management of the people who can't adhere to oral. And then the late presenters or the representers late because they have opportunistic infections because they're not taking oral, and the cost of all of that. So I have never seen a real model to see they're more expensive than injectables. Absolutely, that's a challenge. But how much does it cost? Virological failure because of non-adherence to oral. has never been done. I say this every time, hoping that someone has the brilliant idea to do it. I'm not a mathematician, so I can't do it.
This is a very estoy bien aquí. Bueno, this is a great discover about the treatment of the HIV patients.
Indeed. Indeed, I agree.
Muchas gracias.
Thank you so much for that. Anyone else?
Tenemos más preguntas. Sí, tenemos una.
We have another question over there.
And I work in Cancun in the IMSS hospital. We work in the HIV persons in my hospital, but I would like to ask questions about the injection because we have a lot of pregnancies and breastfeeding in my hospital, and I would like to know when and I can use that injection because we just use only the dolutegravir in the pregnancy.
Yeah, very good question. So at the moment, there's not enough data during pregnancy. They presented data on a very small number of women who became pregnant and then actually stopped, went to oral, and they look at the decay, the PK curve of the drugs, and it seems not to be too bad. However, if a woman is planning pregnancy or is childbearing potential, I think you need a conversation because they need to go back to oral during pregnancy, if that makes sense. I think just a comment, if you don't mind. As you probably know, one of the most vulnerable times of poor adherence for women is postpartum. At IACS, there was a great presentation from Brazil, actually, about comparing postpartum outcomes during COVID versus pre-COVID. There was no difference, but the postpartum outcomes were still worse than any other times. So it could be a great solution for postpartum, if you think about it, right? So if you go through pregnancy with your dolutegravir, follow the guidelines, and then postpartum, you start the injectables to actually support the adherence to pill that becomes lower because of sometimes, the struggles around postpartum. So that's a lot of discussions that were happening at IACS on that. But in terms of using pregnancy at the moment, they're not recommended.
Thank you so much.
Muchas gracias, doctora.
Thank you so much, Ms. Bofito. Now we are going to give you an acknowledgement. We are very thankful to Ms. Bofito and all the people making this question. For sure, in the next few days, you will also have the chance to ask and discuss with other professionals of health. Now, we will ask you, obviously, a round of applause for Ms. Bofito and this acknowledgement. And for the rest of the attendants, of course, Ms. Bofito and all the attendants, we will be waiting for you in the lobby with the welcome cocktail. Thank you so much, and we will continue with our activities for tomorrow.